If you've been swallowing a blood pressure pill every single morning, Amlodipine, Losartan, or Lisinopril, let me ask you something honest. Do you actually understand what that pill is doing inside your body right now? Not the name on the bottle, not the one-line summary printed on the pharmacy bag. Genuinely understand it, how it works, how it can quietly work against you under the wrong conditions, and how to tell the difference between a minor nuisance and something that needs urgent attention today. Most people I speak with, careful people, intelligent people, people who manage their own finances and stay on top of the news, go quiet when I ask that question. And that pause tells me everything I need to know, because here's what matters. These are not mild supplements. These are not vitamins. Amlodipine, Losartan, and Lisinopril are powerful medications that alter how your heart, your blood vessels, and your kidneys function every single day. And yet millions of older adults take them on autopilot, with little understanding of what to watch for, what to avoid, or when something that feels ordinary is actually a warning signal worth taking seriously. Today, that changes. My name is Dr. Adam, and this channel exists for one reason, was to give you the kind of clear, honest, practical health information that gets left out of a 10-minute clinic appointment. By the time we're done here, you'll understand these 3 medications in a way that makes you safer, more confident, and far less likely to be caught off guard. I want to start with a story about a man named Gerald, because what happened to him sets up everything we need to cover. Gerald was 76 years old, retired civil engineer, precise, methodical, the kind of man who kept a written schedule and followed it without exception. When his cardiologist added amlodipine to his existing medications, Gerald figured it was just one more blood pressure pill. Different name, same idea, nothing to worry about. That assumption cost him nearly a year of his life. 3 months after starting the medication, Gerald's feet had swollen so much he couldn't get his regular shoes on. His legs felt like they were filled with wet sand by 3 in the afternoon. He started cutting his daily walks short. He told his wife he thought his circulation was giving out. He was quietly terrified. Searching online for heart failure symptoms at 2 in the morning. The real explanation was far simpler and far more manageable. But Gerald didn't know it, because no one had ever told him that amlodipine, Losartan, and Lisinopril are not the same kind of drug. They all lower blood pressure. That's where the similarity ends. Amlodipine is a calcium channel blocker. It works by relaxing the smooth muscle inside your arterial walls, so blood moves through with less resistance. Lisinopril is an ACE inhibitor. It blocks a specific enzyme that causes blood vessels to tighten. Block the enzyme, the vessels stay relaxed, and pressure drops. Losartan is an ARB, an angiotensin receptor blocker. It works on a similar pathway but through a slightly different mechanism. 3 different drug classes, 3 different side effect profiles, 3 completely different things to watch for. When you understand that, you stop trying to interpret every symptom through the same single lens. Gerald's swelling wasn't heart failure. It was amlodipine doing exactly what amlodipine does in a significant number of patients, relaxing the arteries more effectively than the veins, causing fluid to accumulate in the lower legs. Once that was identified and addressed, Gerald was back in his walking shoes within a few weeks. The name on your bottle isn't just a label, it points to a category, and the category tells you the pattern. Let's go deeper on that swelling, because it's one of the most misunderstood side effects in all of blood pressure medicine. Here's what actually happens. When amlodipine relaxes the small arteries in your legs, blood flows in more freely. But the veins, which carry blood back up toward the heart, don't respond the same way. So there's an imbalance. More blood arriving than leaving. Pressure builds in the small vessels near your ankles. Eventually, fluid gets pushed out of those vessels and into the surrounding tissue. The result? Puffy ankles, sock marks that linger for hours, shoes that stopped fitting, legs that feel heavy and full by late afternoon. This is not water retention from too much salt. This is not your kidney struggling. This is not early heart failure. In most cases, it is a predictable physiological response to how this medication works. Now, here's where it becomes genuinely dangerous. Not the swelling itself, but how people react to it. Some people see the swelling and quietly stop the medication without telling anyone. Their blood pressure climbs back up while they feel like they made a sensible, self-sufficient decision. Others keep taking the medication but start avoiding fluids, thinking they're retaining water. That's the wrong direction entirely. Dehydration on a calcium channel blocker carries its own separate risks, and others, like Gerald, simply endure it for months. They reduce their activity. They assume the worst. They lose quality of life for something that was entirely addressable. The right move is this. Leg swelling on amlodipine is a conversation your doctor needs to have with you. Not because the medication is necessarily wrong for you, but because there may be adjustments, alternatives, or simple strategies that make it far more manageable. Elevating your legs, adjusting the timing of your dose, or in some cases, finding a medication that suits your body better. None of those options happen if you suffer in silence. Now let's talk about Lisinopril and the most well-known side effect in the ACE inhibitor family, the cough. Not a productive cough, not something that brings anything up. A dry, persistent, scratchy tickle at the back of the throat, often worse at night, that doesn't respond to lozenges, antihistamines, cough drops, or anything else you'd find in your medicine cabinet. Here's what makes this one so difficult to recognize. It frequently doesn't start right away. Some people develop it within the first week, others don't notice it until 3 or 4 months into treatment. And by that point, the connection to lisinopril never even occurs to them. They've been on the medication for months without issue. So they blame seasonal allergies, dust, a lingering cold, reflux. I want to tell you about a woman named Dorothy. She was 69, a dedicated gardener. When her cough started in late spring, the timing seemed to explain itself completely. Pollen season, of course. She bought an air purifier, tried antihistamines, and eventually saw her primary doctor, who ordered a chest X-ray. It came back clean. 7 months later, the cough was still there. Her sleep was broken nearly every night. She was exhausted, frustrated, and beginning to believe something serious was being overlooked. When she came to see me, one of the first things I asked was, "When did you start lisinopril relative to when the cough appeared?" She went quiet, pulled out her phone, started working through the dates. She had started lisinopril 10 months before our visit. The cough had appeared roughly 3 months into treatment. She had never once connected the two. When we worked with her primary doctor to switch her to Losartan, which acts on a similar pathway, but does not trigger this type of cough, the tickle in her throat was gone within 2 weeks. 10 months of broken sleep resolved in 2 weeks, once someone connected the dots. Now I need to draw a very clear line here, because there is a symptom in the ACE inhibitor family that is not a nuisance. It is a medical emergency. If you are taking lisinopril and you notice swelling of your lips, tongue, face, or throat, especially if swallowing feels difficult or breathing becomes labored, do not wait. Do not call the office in the morning. Do not take an antihistamine and see what happens. Call emergency services immediately. This is called angioedema. It is rare, but it is real, and it can compromise your airway faster than you would expect. A dry cough is a nuisance. Throat swelling is an emergency. Please hold that distinction clearly in your mind. Now let's talk about Losartan And a danger I find particularly important because it doesn't come from doing something careless. It comes from people doing what they genuinely believe is the healthy thing. Losartan, like Lisinopril, works on the body's blood pressure regulation system. One known effect of this class of medication is that it can elevate potassium levels in the blood. For most people, this stays within a safe range when properly monitored. But add certain common lifestyle choices on top, and the picture shifts. Here's where it becomes counterintuitive. Potassium isn't only hiding in bananas or supplements, it's in products actively marketed as the healthier option. Salt substitutes. Many low-sodium alternatives sold right next to regular table salt, often labeled heart-healthy, replace sodium with potassium chloride. So an older adult who's been told to cut back on salt goes to the grocery store, buys a potassium-based substitute, uses it freely on every meal, and is now loading potassium into a system that's already being pushed higher by their medication. The combination can drive potassium to levels that affect the electrical activity of the heart. And here's what makes it especially dangerous. Elevated potassium doesn't always announce itself loudly. It can appear quietly as unusual muscle weakness, persistent fatigue, cramping in the legs, tingling in the hands, or a fluttering irregular heartbeat. Sometimes there are almost no warning signs at all, right up until there are very serious ones. Electrolyte powders, certain meal replacement shakes, and some over-the-counter recovery drinks also carry significant potassium loads. They're not prescription products. Nobody thinks to mention them, and that's exactly why they matter. If you or someone you care about has switched to a salt substitute in the past year or two and takes Losartan or Lisinopril, that is a conversation that needs to happen with a doctor. There is one scenario that doesn't get nearly enough attention, and it affects older adults more than any other group. What happens to these drugs when you get sick? Not seriously ill, not hospitalized, just a rough stomach bug, a few days of vomiting, diarrhea that won't quit, a hot stretch of summer with heavy sweating and not enough fluids. When you're dehydrated for any reason, the same dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated body can behave in dramatically different ways. Your blood pressure can fall too low. Your kidneys, already under strain from fluid loss, become more vulnerable. Dizziness, weakness, lightheadedness, or acute kidney stress can develop faster than most people would anticipate. The medication didn't change, your body's internal environment did, and the drug is now operating in conditions it was never designed for. This is one of the most practical things I can share with you today. Illness changes the rules. And if you don't have a clear plan in whether to hold a dose, when to call your doctor, which symptoms mean it's time to go in, you are leaving a meaningful gap in your safety. That plan should come from your prescribing physician before you ever need it. If you don't have it, ask at your very next appointment, what should I do with my blood pressure medication if I get a stomach illness and can't keep food or fluids down? It is one of the most important questions you can ask, and one of the least commonly asked. Let me paint you a picture worth visualizing clearly. You've had a rough week, your joints are aching, your lower back is stiff. You stop at the pharmacy and pick up ibuprofen. Something you've used for years, something completely ordinary, something anyone can buy off the shelf without a prescription. Now you're taking Lisinopril or Losartan, perhaps also a diuretic for additional fluid management. That combination, used regularly, can meaningfully reduce blood flow to the kidneys. And in the presence of even mild dehydration, the risk of kidney injury rises considerably. This is not a rare theoretical scenario. It is one of the most common, most preventable situations I encounter, and the reason it keeps happening is simple. Patients don't think of ibuprofen, naproxen, or similar over-the-counter anti-inflammatories as medications in the same league as prescriptions. They're just something for the pain, something from the drugstore. But your kidneys don't distinguish between prescription and over-the-counter. They respond to chemistry. If you regularly use anti-inflammatory pain relief for arthritis, joint pain, or back pain, and you're taking any of these 3 blood pressure medications, please have that conversation with your doctor. There are often safer alternatives. Acetaminophen, topical treatments, physical therapy, approaches that don't carry the same kidney risk. You don't have to simply accept the pain, and you don't have to silently accept the risk, and there's usually a better path available. I want to spend a moment on something that sounds minor and isn't. Dizziness, that brief, unsteady feeling when you stand up from the sofa or rise from bed in the morning. The room tilts for a second. You grab the door frame, it passes, you carry on thinking you just got up too fast. For many older adults on blood pressure medications, this is a regular experience, and it is almost universally underreported because it seems too insignificant to mention. Here is what I need you to hear. In older adults, a few seconds of dizziness is enough to cause a fall. A fall is enough to cause a fracture, and a fracture, particularly at the hip, can alter an older adult's health trajectory in ways that take years to recover from, if recovery comes at all. This isn't alarmism, it is physics and biology working together in a way that demands genuine respect. The dizziness happens because your medication is doing its job, lowering blood pressure. When you stand quickly, your cardiovascular system hasn't had a moment to adjust. Blood pressure briefly dips. Blood flow to the brain decreases for a moment. You feel it as that tilting, lightheaded sensation. The solution is often straightforward. Rise slowly. Sit on the edge of the bed for a moment before standing. Hold something stable. Give your body a few extra seconds to catch up with the change in position. But dizziness that happens consistently, dizziness that doesn't settle after the first few weeks on a medication, or any episode of near fainting, those deserve a real conversation. The dose may need adjustment. The combination of medications may need review. Something in your hydration habits may need to change. Staying silent about this one is not a small risk. Let me address something that creates unnecessary anxiety and occasionally leads to dangerous, impulsive decisions. For people managing blood pressure at home, blood pressure is not a fixed number. It shifts constantly throughout every hour of every day in response to dozens of variables: how well you slept, whether you've had caffeine, whether you're in pain, whether you're anxious about the reading itself, whether you just walked in from outside, whether you spoke loudly right before sitting down. A single high reading on a random morning after poor sleep does not mean your medication is failing. A single low reading after a hot, dehydrating afternoon does not mean your dose is too strong. What matters is the pattern, measured consistently. Same arm, same time of day, after 5 minutes of quiet rest, without rushing, without talking. When people monitor inconsistently and react to individual readings emotionally, the decisions that follow are almost never the right ones. Extra doses taken out of fear. Skipped doses because one reading looked fine. Frantic calls to the doctor about a number that, in context, was completely unremarkable. Monitor deliberately. Track over time. Bring the log to your appointment. Let patterns guide the conversation, not panic. That shift alone reduces anxiety, improves decisions, and gives your doctor far more useful information than a single alarming screenshot from your home device. These medications work through steady, consistent presence in your system, not through spikes and gaps, not through extra doses when you're worried, not through skipped doses when you feel well. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not designed to be taken reactively the way you'd reach for a pain reliever after a headache starts. They are designed to create a stable chemical environment inside your cardiovascular system, maintained over time. When consistency is broken by missed doses, double doses, or erratic timing, blood pressure can fluctuate in ways that feel like the medication isn't working, when the actual problem is the pattern of use. If you miss a dose, the general guidance for most blood pressure medications is to take it when you remember, unless it's nearly time for your next scheduled dose, in which case skip it and continue normally. Never take 2 doses to make up for one missed. But rather than rely on general guidance, ask your prescribing doctor for specific instructions. Write it down, put it in your phone, keep it with your pill organizer, because in the moment when you realize you've forgotten, you don't want to be guessing. I want to close with what I believe is the most important point of this entire conversation, and one that often goes unsaid. The best blood pressure medication is not the one that produces the most impressive number on a chart. It is the one you can take safely, consistently, and comfortably, within the full reality of your health, your habits, your other medications, and your daily life. A medication that looks perfect in a clinical chart, but keeps you up every night coughing, swells your legs until you stop walking, or makes you afraid to get out of bed in the morning, that is not a successful medication for you. Side effects are not a character flaw. They are not you being overly sensitive. They are information. They are your body communicating through the only language it has: symptoms. And those symptoms deserve to be heard, evaluated, and responded to thoughtfully. Too many older adults endure side effects in silence because they assume, I need this medication, so I have to live with it. That assumption is not medically sound. There are almost always options: dose adjustments, timing changes, alternative medications, combination strategies, but those options only become available when you speak up. Silence is not compliance. Quietly suffering through a side effect that makes you dread taking your medication each morning is not dedication. It is a setup for the day you stop taking it entirely without telling anyone. And that is when blood pressure rises back up, when everyone is caught off guard. Your voice is part of the treatment plan. Use it. Here is the simple framework I want you to carry with you from today. If you take Amlodipine, it's watch for leg and ankle swelling, especially by late afternoon. Report it rather than endure it. If you take Lisinopril, watch for a persistent dry cough that doesn't respond to anything, and know that swelling of the throat or tongue is a genuine emergency requiring immediate care. If you take Losartan, watch for signs of elevated potassium, muscle weakness, irregular heartbeat. Review what's in your salt substitute, and have a sick day plan ready before you need it. With all 3, rise slowly to prevent falls. Monitor blood pressure with a consistent method. Never combine casually with anti-inflammatory pain relievers without guidance. And never stop abruptly without speaking to your doctor first. You took the time to be here today. That tells me you take your health seriously. I hope what you've heard gives you something real, not fear, but clarity, because clarity is what turns a prescription in your hand into a treatment plan you actually understand. If this reached you, or share it with someone you love who's managing blood pressure, because this kind of information quietly protects real people from real harm. And if you want more of this, the honest, practical kind, subscribe to Dr. Adam's channel, because this is just the beginning.